Now we are moving on to the next segment for the day, which is a fetal medicine. May I please call upon the experts onto the stage, Dr. Dhanya, Dr. Karthika, and Dr. Akhila. The chairpersons are requested to kindly be on stage now. We are moving on to the first session on fetal medicine. The first trimester scan, glimpse beyond NT. This is presented by Dr. Manikandan. May I please welcome him aboard? He is the consultant maternal fetal medicine and fetal therapy specialist. He has a postdoctoral fellowship in fetal medicine from the TN, Dr. MGR Medical University, and he has a research fellowship training at King's College Hospital, London, and he is also a member of the Fetal Therapy Committee of the Society of Fetal Medicine India. Over to you, sir.
Thank you very much, and very glad to come again to Advances 25. We have all been taught and we have been teaching our students the traditional antenatal care, one visit per month in the initial part and then more frequent visits in the later part. And this is a traditional pyramidal way of looking at stuff which was originally designed way back in the 1930s by the Ministry of Health UK on the recommendation of the Ministry of Finance, because they could only afford that time. But this was based on the understanding of disease manifestations and primarily geared to stem the maternal mortality. So because that's during those days we were only able to pick up diseases when it happened. So we need to wait till the pathophysiology ripened enough for the clinical manifestation. This is Professor Nicolaides, wise old man in his 70s, this year 2025. But 33 years ago, this is his younger days, feverish about one concept, NT. He was possessed by it. He spent decades on that, thousands of patients, lakhs of patients, millions of money spent into one thing, NT. So it sees the world of fetal medicine, NT everywhere. But indirectly, it also changed the way fetal medicine is being practiced today, and to a large extent, how obstetrics is practiced today. So we'll see the impact of this, and we'll see what we can offer today at the NT scan, the so-called NT scan, which is no longer the NT scan. In the 70s, when Dr. Ian Donald brought ultrasound into the picture of obstetrics, it was to avoid a double setup examination, and later they were able to measure some biometry, find some fluid, and manage post-dated pregnancies. And then it evolved in the 80s to find out certain common but very bad abnormalities like open neural tube defects, anencephaly, spina bifida, etc. In the 90s came that feverish struggle with NT, and that was largely pioneered by Professor Nicolaides and his team. And it spent so much resources that over the next 2 decades, we now have the entire fetus in our grasp, largely in the first trimester. This is thanks to, as I have mentioned, to pioneers like him, but also due to advances in medical engineering. The ultrasound systems have evolved so dramatically. But also because of the extraordinary time that was spent in the early fetus, because we wanted to do NT better and better and better, a larger time was spent, which consequently resulted in more expertise, familiarity, and identifying and understanding the pathology of many diseases, related diseases in the first trimester, and also because of the public and media expectation on what technology can do. So a glimpse beyond NT, we'll start by looking at the etiological perspective of diseases of the fetuses, which is the reason for a pregnancy, from fetal medicine point of view. So if you see, about 5 to 10% of all fetuses problems can be attributed to the maternal diseases, and about 15%, if you ask Bijoy, he'll say 30% in our population, maybe true, is actually true, will be result of growth restriction, and about 10% maybe because of prematurity related problems. only 2 to 3% organ related problem. The much hyped anomaly scan, only 2 to 3% in the large scheme of things. And Down syndrome and related chromosomal abnormalities, 1 in a 700 to 1 in a 1000 births. And even rarer will be the single gene disorders that I'm sure we will be discussing at much larger length. But what kills the babies? What contributes to the perinatal mortality? The usual culprits are placenta, prematurity, defects, together constitute 90%. The rest constitute only 10%. So, we will see whether we can address these major culprits in the first trimester itself. Culprit 1, placenta. This is largely, if you look at Indian data, a large proportion will suffer suboptimal growth secondary to placental dysfunction, and we need to identify these pregnancies to prevent mortality and morbidity for the baby. But we also know that the placental dysfunction can take another route and cause distress to the mother in terms of severe preeclampsia, early onset preeclampsia. That can be very difficult to manage if we are not ready for that. Placental dysfunction or growth restriction has been the single most common etiology if you look into unexplained stillbirths that once in a while we meet in our practice and we are really depressed at the end of the day. How did it happen? But the reason is placental dysfunction, silent growth restriction. So we need to identify that. And we know that although it is in the late second trimester, the baseline risk factors operate pre-pregnancy or even in early pregnancy, and the first step in the pathophysiology, which is defective trophoblastic invasion, happens very early in the first trimester. This then leads to placental ischemia, oxidative stress in the first and early second trimester. That then starts a vicious cycle involving vasoactive factors, immunomodulators, inflammatory mediators, which set up endothelial dysfunction, which goes back and causes more placental damage. And the process keeps repeating until the disease manifests as a clinical problem in the late second trimester or early third trimester. So we should not be acting there, rather we should act at the beginning. So from traditional risk factors of obstetric history, medical history, and your clinical findings, we should move forwards and earlier by identifying new risk factors. Well, all of you do Down syndrome screening. If somebody is screened positive for Down syndrome, but the baby is okay, the fetal medicine says there is no aneuploidy, mark that patient as high risk for placental dysfunction. A simple way to identify. There's going to be FGR in the coming days. A Doppler finding, if you had asked your imaging person to do a routine Doppler of the umbilical artery, uterine artery, and the mean PA comes high resistance. That is a risk factor for FGR or placenta-based problems. And straight away, ultrasound findings of the placenta in the second trimester also are important. You should have a good-looking placenta. That's the crux of the issue. So look at the placenta also. And in the first trimester, a combination of blood flow in the uterine artery impedance, that is your Doppler PI, and potential placental protein secreted, PLGF better than PAPE, but if you don't have PLGF, at least base it on PAPE. You will be able to predict the severe, unmanageable, the morbid preeclampsia, that is the preterm preeclampsia. You will be able to predict it to a large extent, prevent it to a large extent. And also you will be able to predict the non-PE, non-preeclamptic FGR, early FGR also. And we know that there is a intervention that is available, easy and quite effective. So aspirin we can start once you predict preeclampsia, and FGR you can start aspirin and prevent it to a large extent. So to summarize, the first culprit, placental problem, dysfunction, by 12 weeks we'll be able to have a very good prediction, very good prevention by simple intervention for preeclampsia, and for that constitutes a large of FGR also. And for those FGR which are without preeclampsia, you will have a reasonable prediction and prevention by the same strategy. Now let's move on to the second culprit in perinatal mortality, which is the congenital malformation. Today, the ISUOG mandates a 20 plus 2 planes to cover about 50 abnormal appearances in the standard second trimester screening, which is the morphology scan or the anomaly scan. But your screening can start much earlier in the first trimester itself, and many of the bad problems can be picked up there. This baby is jumping. Can you say which condition it has excluded already? It has excluded a lethal condition called fetal akinesia dyskinesia syndrome, deformation syndrome. So that sequence is excluded. So you can be confident, okay, so the baby is not having a FUS. That's a lethal entity. So you measure the CRL. If you can't measure and you find a very twisted, torted fetus, this is a lethal condition called body stock anomaly. And in the same image, when you see a bladder too much distended, there's something going on, problem with the fetal uropathy. Obstructive uropathy is highly likely, so it requires some follow-up. You see a nice head with two choroid plexus and a nice ossified calvarium at 12 weeks. You see a single cavity inside. You don't see a separated choroid plexus. That's a hollow prosencephaly. You don't see the calvarium itself. The brain matter is freely floating. That's acrania, which will become anencephaly in the second trimester. You can see the heart. Make sure that there are two good inflows going and then two outflows coming out. You have excluded the poor prognosis cardiac defects. So you can move on. Okay, the heart is okay to continue. Sometimes you will pick up abnormalities in the heart itself, but that will require a little bit more training. Whereas you can say, okay, this is fine in the first trimester. Then you can also see the cord insertion, the integrity of the ventral wall, which when you don't see it, you can see gastroschisis, large omphalocele, so that will initiate a bit of evaluation. First trimester is also the best time to look at the malformations or abnormal formation of the limbs, because everything in one go you can see. Unlike the second trimester where the fetus keeps it folded, hidden, in first trimester everything is seen in full. So you can see all the three segments, limbs, digits, everything. Not that you have to go and count it, but you can have a gestalt appearance. Okay, everything looks fine, I am moving on. So you can pick up some not incompatible with life, but no parent will try to continue a amylic child, a phocomyelic child. Similarly, for spine, which has been something that was hidden from our view for a long time, and once we realize that there are simple signs in the baby's brain, in the NT image itself, if you see, you have to see 3 black strips here. If you see only 2, that means there is a problem in the spine down. So you will go and pick up a spina bifida, open spina bifida, even in the first trimester. And we all know that's a condition that is associated with much morbidity than mortality, and early termination can be offered. Not only is the first trimester anomaly scan required to pick up individual anomalies, but it can also solve genetic syndromes. The classic example is Meckel-Gruber. Nowadays, we don't offer genetic evaluation if there is a family history of Meckel-Gruber. You come back at 12 weeks, we will say if there is recurrence or not. In fact, our fellows diagnosed one at 10 weeks. So we said, hold on, come back at 12 weeks, the full manifestation, let it come. So certain genetic syndromes you can pick up and diagnose at 12 weeks also. From a fetal medicine perspective, what are all the problems of the fetuses? How can we classify? We tend to look at it, is there a problem that requires an intervention antenatally or postnatally to optimize? Is it correctable by surgery? Is there a need for in utero treatment? Do we have to pitch in when the baby is still inside? In utero surgery is required, or then we have to resign and say, no, it's fatal, incurable, we can't do much about it. And then the last one is postnatally we have a reality check, okay, this is missed because this we cannot define. The first trimester focuses on the penultimate one, fatal, incurable defects. We must focus on that in the first trimester, and that is largely our effort in the first trimester. What are the fatal, incurable defects that we can pick up? And if so, we can communicate clearly to the parents. So to summarize, second culprit in the first trimester, by 12-13 weeks, and you need to optimize your timing, it's after 12 and before 13. More than 95% of all lethal structural anomalies, I'm not talking about inborn errors of metabolism, structural anomalies can be identified. More than 80% of major defects, by which I mean defects that require a major surgery or that will leave the child with handicap can be identified in the first trimester using a proper protocol under an expert. But there are pitfalls. We should be very careful about the pitfalls. You should not overcall false positives or possibles, so you should not overcall borderline findings. And there will be evolving anomalies second trimester, third trimester, so counseling has to be adequate. You are only excluding 80%. And what happened to correctable anomalies? Say, for example, you find a tetralogy of Fallot. If I find it in the second trimester, I will always be counseling. It's correctable, don't worry. Let's just exclude the genetic. It's a good prognosis. TGA. What happens in the first trimester when you flag a correctable anomaly, inevitably it gets terminated. Although the first trimester anomaly is very much capable of finding many of the things, it does not bring down the second trimester importance. Rather, you should say, lady, we have seen you well. When you come in for the second trimester anomaly, your chance of getting a major diagnosis falls from 2% to less than 0.5%. Come back with confidence. Let's go to the third culprit of perinatal mortality, the preterm birth. Preterm birth is a combination of asynchronous activation of myometrium, quiescence, membrane integrity, and cervical support. So when you have an asynchronous activation, ultimately it will end up in preterm birth, but as the previous, Sangeeta madam has rightly pointed out, there will be some way in which it can start and then everything falls into the same category of pain and labor. What we have understood is just by history alone you cannot predict. You can predict maybe up to 15%, and if you add a biophysical marker like a cervix, then you can predict up to 50%. So this cervical length, unfortunately, we are still not very happy with its performance in the first trimester. So today, as we speak, I offer it only in the second trimester, but in the first trimester, we can use certain things that are associated with preterm births, that is evaluation of the twins. Assigning chorionicity is a major factor that will help you in managing and avoiding preterm births by virtue of knowing what pregnancy you are dealing with. Also, finding if it's a triplets and offering reduction in the correct cases will also drastically reduce the preterm birth. So to summarize, although preterm birth can be addressed efficiently in the second trimester by routine examination of the cervical length, in the first trimester the benefit is not yet so direct as in the second trimester. Going to the fourth culprit, which is chromosomal defects. This is the basic purpose for which the NT scan came. Down syndrome became diagnosable in the lab and women wanted termination because abortion became legal. So these two factors brought together made the government offer amniocentesis, and then to know which cases will do better on amniocentesis, screening came into view. So the screening, when you do it properly, the combined screening test is still a good test. Do the nuchal properly, do the bloods properly, you can detect 90% of Down syndrome. And in addition to Down syndrome, using the same markers, you will also be able to find out some bad other aneuploidies like 18, 13, and even Turner syndrome. So to summarize, the original purpose is still good, it still holds good. A combined first trimester screening, the term is very important, combined first trimester screening at 12 to 13 weeks would still detect 90% of aneuploidies at a 3% invasive testing rate. There are some limiting factors. Tomorrow you cannot expect every center to give you the same results. You should have expertise, motivate your imaging person to go for further training. It should be protocol based and you should have allotted enough time. You cannot call and you cannot be impatient when you send a patient for fetal medicine opinion. Gestational age is vitally important. It's better done at 12 weeks and above rather than at 11 to 12 weeks, even though technically the NT scan will hold good at 11 to 12 weeks. If you want to get all the benefits, 12 to 13 weeks. Of course, like in any ultrasound based thing, maternal habitus is a major pitfall. Fetal factors also play some role, so position and happens to be a limiting factor. So my key messages for a cutting edge practice to all of you is do the 12 weeks scan, use it fully to exclude lethal anomalies, aneuploidies, severe preeclampsia. Bring back at 20 weeks for an additional risk assessment of preterm birth. Having done all these things, from 34, 32, 36 onwards, look for the late FGR and prevent those unexpected stillbirth. Thank you very much.